So as Andrew and Judith mentioned, I'm going to talk about the neurobiological work package linking electronic health record data to imaging cohorts and routinely collected imaging data. And I'm going to frame this really based on two questions. So firstly, can we use electronic health record data to supplement neuroimaging research cohorts that are already in existence? And secondly, can we tap into data from routinely collected clinical brain scans for mental health research? So the first cohort I'm going to talk about is the Scottish Bipolar Family Study. So this is a prospective longitudinal study for those of you who are not familiar with it. The individuals were recruited into the study in 2007, and there were about 300 individuals. They were recruited between the ages of 16 to 25, and they were essentially recruited into a high-risk or low-risk group based on a proximal family history of bipolar disorder. So there were approximately 150 high-risk individuals and approximately 150 low-risk or control individuals. And the purpose was to follow them over about 10 years to see if we could predict those who were most likely to become ill from the baseline assessments, just basically to follow them prospectively. So they were seen approximately every 2 years, where we collected a wealth of data, including neuroimaging data of several different modalities, genomics, cognition, behavior, lifestyle, and clinical assessments, as you might imagine. So it's important to consider that they all had to be well at recruitment. That was one of the inclusion criteria, that they couldn't have an existing diagnosis of psychiatric conditions. So in 2007, they were all initially well when they were recruited into the cohort. And you can see that over the years, there are a number of individuals who have remained well, but at each assessment, we've also picked up a number of individuals who have become ill, and that was primarily with major depressive disorder and a smaller number with bipolar disorder. Similarly, there were larger groups in the high-risk cohort who became ill, but there were also similar numbers in the low-risk group as well. But as you might imagine, with a longitudinal cohort, there are always individuals who are lost to follow-up. And on some of the individuals who we did get information back, some of that was quite patchy. So in 2017, we decided that we would try and access health record data for this cohort. And we received that in 2019. So that covered the period from 2007 to about May 2019 when we received the data. And that included outpatient data, inpatient data, maternity, mental health, cancer, deaths, and prescribing information. So I'm just going to give you a flavour of what that data looks like. So this is the outpatient data attendance shown on the left-hand side. So we had data on 186 participants, and you can see that general psychiatry was the topmost specialty if we rated by the number of appointments associated with each specialty. And when we look at the number of subjects seen, there were 35 individuals who were seen in a general psychiatry outpatient clinic. And I just like to reiterate, because I think it's an important point, that these individuals were all actually well at recruitment. And in terms of mental health inpatient clinic visits, there were a number of diagnoses that subjects received. There were 6 individuals who were diagnosed with bipolar affective disorder, 7, 6 with unipolar mood disorder, and smaller numbers of other disorders that were diagnosed in this initially well population. So in actual fact, this allowed us to generate new diagnoses for 6 of the participants within the Bipolar Family Study. And by new diagnosis, I mean new to us in the sense that we weren't aware of the diagnosis before that. But often with this type of work or this type of cohort, the disorder that individuals become ill with is major depressive disorder, and that's often not seen in these types of mental health clinics. So we referred to the prescription data from this sample. And this was much fuller than the other outpatient and inpatient data. So we had prescription data on 215 of the participants, which is almost 80% of the cohort, with around 13,000 data points. And the panels on the left for the controls and the high risk, I think just demonstrate nicely the richness of the prescribing data through the years. So each row represents an individual with the prescribing data, obviously demonstrated as the points along that pathway from 2009 to 2019. And you can see in general that there were more prescriptions for the high risk group than there were for the control group. And we've separated out the types of prescriptions into the different types of psychotropic medication, split by controls and high risk. And you can see that the anxiolytics and antidepressants are the most often prescribed, and there's more prescriptions within the high risk cohort. So you can see that there's a richness to this data that we didn't have before, and we can combine this electronic healthcare record linkage data with the research data to look at this and revisit this cohort in a much more complete way. So the second question I'm going to address is whether we can tap into the data from routinely collected clinical brain scans for mental health research. So this is based around the idea that psychiatric symptoms are common in neurological conditions like stroke and dementia and multiple sclerosis. And we know the presence of both impacts recovery and quality of life, but the mechanisms and the details of that are rather unknown. So here we've used text mining of electronic health record linkage to link these two clinical specialties together. And we've done this by linking neuroradiology reports with mental health data. And this involves applying machine learning algorithms, specifically natural language processing, to text mine information that's existing in the neuroradiology reports. So this is an example of an annotated report. And the system we're currently using is a rule-based method called EdiE-R. And you can see from the annotated report that there's report labels. I don't know if I'm hoping you can see my cursor, report labels here. And the algorithm pulls out information about the location, which is usually specified as either deep or cortical. It pulls out a temporal element, whether it's an old or a new lesion, and it pulls out entities of interest like small vessel disease and various forms of stroke. And the rules were developed in an iterative process between the system itself and the neuroradiologists. And again, it was tested on unseen data, and the work's published by B. Alex in 2019. Two other features of this natural language processing algorithm I think are worth highlighting. So again, this is an annotated report on the left-hand side, and you can see some of the modifiers and the entities that I mentioned previously are identified here. But interestingly, you can see that there's an acute hemorrhagic stroke, which is being pulled up here. But this is in the context of a no feature here. So it's important to also implement negation detection techniques within the context of these types of algorithms. And this has also been developed as the rule within the algorithm that we've got. And again, it's been recognized that this is a negated entity, so we're not to include that within the annotation. This is an example of some spelling mistakes in your radiology reports, and if anybody's interested, I really recommend going to the web demo that we have here, where you can type in a neuroradiology text report and it will annotate it in real time for you if you then hit go. And we can see just an example of some of the correctly identified annotations. So evidence of an old, and this has been annotated as a time old. Left posterior temporal, which has been annotated to be a cortical lesion. But you can see that there are some spelling mistakes further down here. So infarct, which is a rather unfortunate one, which has actually been correctly identified as infarct, of course, as an ischemic stroke. Hemorrhage with lots of R's in it, which is probably one of the most commonly mistyped features, is being correctly identified as a hemorrhagic stroke. And my favourite at the bottom is acute stroke. Obviously, it's been correctly identified here as being acute, not acute. So the implementation here, we've conducted this in 2 separate steps. So the first within a consented cohort. So this is within Generation Scotland, which is around 23,000 individuals who already have in-depth phenotyping and health record linkage. And the health boards that are involved here are Tayside, Grampian, Lothians and Greater Glasgow and Clyde. And the idea here is that we can link, once we've run the natural language processing algorithms over the neuroradiology reports, we can link these to Generation Scotland phenotypes from research and from other health record linkage information. And on the right-hand side is implementation at the Scotland-wide level. It's a complex flowchart, which I won't go into, but I've just highlighted anonymisation because this was one of the main sticking points for getting data out of EDRIS. But we were actually able to help one of our members of the group and some of his team were able to help EDRIS develop anonymisation software, which we can then use to release the data in a safe way. And that's something that will be used in other studies in the future, I'm sure. So I just thought I'd show some demographics for some of the participants that we've had reports on. So these are from Tayside and Fife. There are about 2,000 individuals from Generation Scotland who had routine clinical neuroradiology reports. And there's a distribution.
Just wait a minute. Yeah.
Okay, there's a distribution of age and gender at the bottom and the number of scans that participants have. So you can see that most individuals have 1 scan, but there are a number of individuals who have more than 1 scan. And these are some of the brain phenotypes that we've pulled out. So the most common being atrophy, small vessel disease and tumours and others. And this is just separated by males and females on the right-hand side. So you can see males have slightly more atrophy and females have slightly more small vessel disease. So the next steps are to process the data from the other NHS health boards for Generation Scotland and then roll this out for the whole of Scotland. And then link to the mental health phenotypes. We're constantly involved in methods development, so benchmarking the different algorithms against other types of features, so deep learning algorithms, for example, and looking at transferability across health boards. And there's 2 systematic reviews based on clinical and methods-based NLP within the literature. So I won't go into that. I'd just like to finish up by saying thanks and acknowledgements to the participants, the funders and the many collaborators, and particularly to the Natural Language Processing Group at the University of Edinburgh. Thank you.
Brilliant.